So thank you for the invitation to discuss cardioplegia administration technique. The outline of my talk is to discuss, first of all, what's the goal of cardioplegia? How does it work? What's the role of hypothermia, myocardial arrest? How much of an impact does it have? What are the different types of cardioplegia compositions that are most commonly used, and what are the methods of administration? So as many of you are familiar with ischemic injury, it really occurs when oxygen supply doesn't meet the demand. This is an important basic principle, but we often tend to forget it. It's inadequate oxygen delivery and inadequate waste removal. And for that, we need to remove both carbon dioxide, but also lactate, and importantly for the heart, protons, hydrogen ions, which can cause injury and particularly during reperfusion. Warm, unprotected ischemia is not well tolerated, and particularly in the myocardium. Short periods can cause stunning, and slightly longer periods, and even moderate hypothermia can cause necrosis. So what happens during ischemia? Well, the main problem that occurs is that you lose the ion gradients that occur between the extracellular space and the intracellular space. There's a huge gradient of sodium. 8 times more sodium outside the cell than inside the cell. But the one that does the most damage is calcium. There's 1,200 times more calcium outside of the cell than inside of the cell. So there's a mechanism for maintaining the calcium levels extremely low. Calcium entry into the myocardium is what causes contraction, which is the force that's generated to make the heart beat. But we also have energy requiring mechanisms to pump this calcium out. During ischemia, energy is is lacking, and so calcium entry is no longer pumped out, and that causes activation of all kinds of mechanisms which lead to cell death, either acute infarction or programmed cell death or apoptosis. So what are the guiding principles for myocardial protection? They're very straightforward. The first is to reduce oxygen demand, and we have a couple of ways of doing that. Prevent sodium and calcium entry into the cell, and there are ways to formulate the solution that bathes the heart through the coronaries to try to mitigate that. And then there are other ways to increase ATP production, albeit usually at a very low rate. So what are the ways that we have to reduce oxygen demand? Well, this graph actually shows you quite well what is the most impactful thing that you can do to reduce oxygen demand. This is a graph showing temperature, and both in the empty beating heart and here in the arrested heart. And here is oxygen demand on the y-axis. So empty beating, it's requiring a large amount of oxygen because it's contracting. As soon as you arrest it, about 1/3 of the energy is required as when it's beating. But as you lower the temperature, and noted even modest degrees of hypothermia reduce the oxygen demand. Cardioplegia most of the time is administered at very low temperatures, typically in the teens or even low teens. And what this allows you to do is reduce the demand sufficiently so you can go for relatively long periods of time without injury to the cell. So how do we arrest the heart? Well, there's a couple of methods. Potassium is the most common one. High dose or high concentration of potassium is very effective. It's rapidly active. However, it also washes out and therefore often requires repeat dosing. So many forms of cardioplegia requiring multi-dosing, typically every 20 minutes or every 30 minutes. The other disadvantage though of potassium is that it opens the sodium channel, so it lets sodium into the cell, and that's potentially a problem because remember, that's one of the ions we're trying to keep out. What are the other methods? Well, there are hyperpolarizing techniques or chemicals that actually close sodium channels, the most common of which is either procaine or lidocaine. And you can add that to the cardioplegia to achieve what we call hyperpolarizing arrest. This is a graph of the different types of cardioplegia that are used most commonly. Buckberg blood cardioplegia in a concentration of 4 parts blood, 1 part crystalloid. And it's an extracellular solution with sodium and potassium being high to achieve arrest. And then these other additives, including glucose being the most important one for substrate. And maintenance is still at 4:1, 4 parts blood to 1 part crystalloid, being given typically every 20 minutes. Cardioplegia that I typically use is the inverse of that. So it's 1 part blood to 4 parts crystalloid. So it's mostly crystalloid. It is extracellular, but it does have lidocaine, and the lidocaine is the most important component as far as prolonged arrest. Custodial, which is a purely crystalloid solution, is an extracellular. If you look at the sodium concentration in comparison, it's much, much lower than it is in either Buckberg or in my cardioplegia. So the concept is very different. It uses histidine as a buffer to wash out protons, and the dosage of administration is substantially greater. So how do we administer the cardioplegia? An example of my cardioplegia, most commonly it's administered antegrade, in other words, through the aortic root down the coronaries. What are the other ways to administer cardioplegia? Well, you could do it retrograde through the coronary sinus. Mostly gets the left ventricle. Very little of that goes to the right ventricle. But if you need left ventricle, that's the way to do it. The dosage that we typically use is 20 mL per kilogram. It's the initial dose. Typically, it's about 1 liter for an adult, and then about half a liter repeat dose, typically after 45 to 60 minutes. As I said before, the other way to administer it is retrograde into the coronary sinus. This almost always only gets the left ventricle. But if that's what you're trying to protect, it's actually quite effective that way. This is helpful when you have aortic valvular regurgitation or situations where administering it antegrade is challenging, or you can simply administer it directly into the coronary ostia, typically through a cannula, which has a button in it that allows you to direct installation into the coronary ostia. Clearly here, the rate of administration is important. It's very easy to administer it too hard or too fast. That damages the endothelium and causes a lot of petechiae and hemorrhage in the myocardium, and ultimately quite a bit of damage. So the rate of administration is important. Typically, we like to use physiologic pressures, which is usually 50 millimeters of pressure, which is diastolic pressure. And the perfusionist needs to monitor that and needs to control that very carefully. So to summarize, the goal of cardioplegia is to preserve the myocardium during ischemia. Cold temperature is critical. Probably the single most important factor that you can do is less than 20 degrees. Cardiac arrest is the second most important thing that you can do to protect the heart, either using potassium or lidocaine or a combination of both. The route of administration is most commonly antegrade down the aortic root or directly into the coronaries or in the grafts, or you can use retrograde, particularly if you want to protect the left ventricle. And there, the pressures that you're using are much lower, typically about 30 millimeters of mercury pressure. The dosing can be single dose or multi-dose, depending on the type of cardioplegia. For the Buckberg, it's every 15 to 20 minutes administration. Similar for the crystalloid solutions. For my cardioplegia, because of the lidocaine, you can use single dose up to a period of about 60 minutes. Some have advocated beating heart warm temperatures. I think that even though this technique can be used, I think it's quite dangerous and needs to be done very, very carefully. So we typically will avoid it. Thank you very much.